All right, welcome. If you're studying for your anesthesia exams, this one's for you. We're going to tackle two absolutely critical topics, hypoxia and shunts, and really break them down into the key concepts that you've just got to know.
Okay, let's just jump right in with a scenario that, well, it gets your heart rate up, right? The monitor starts alarming, that saturation number is ticking down. To fix it, you have to understand what's really happening at the most basic level. So let's start at the very end of the line, the cell itself.
So what is hypoxia really? This definition is absolutely key. It's not just about low oxygen floating around in the blood. It's that final critical failure. It's when the little powerhouses in your tissues, the mitochondria, literally can't use oxygen to make energy. This is the endgame for a whole bunch of different problems.
So to figure out what's going on, you gotta have a system, right? A way to classify the problem. This is how you start building that differential diagnosis when things are going south. And there are basically four main ways this whole cellular failure thing can happen. And this table is just fantastic because it gives you the whole framework. Now, hypoxemic is the one we always think of first, right? A problem with the lungs getting oxygen into the blood. But look at the others. You could have anemic hypoxia, not enough hemoglobin, not enough buses to carry the oxygen. Or stagnant, the circulation itself fails, the buses can't get to their destination. And then there's cytotoxic, where the cell itself is basically poisoned and can't use the oxygen even if it's delivered perfectly. See? The problem isn't always in the lungs. Okay, for the rest of our time here, we're going to really focus in on the big one, the one you'll be managing all the time in the OR, hypoxemic hypoxia. This is all about what's going wrong inside the lungs. So when we're talking about hypoxemic hypoxia, there are really four main culprits. You've got hypoventilation, pretty straightforward, you're just not breathing enough. Then diffusion limitation. There's a problem getting O2 across that membrane between the air sac and the blood. Now, both of those are important, but for your exams, the real money is in knowing the difference between the last two, V/Q mismatch and shunt. Getting that distinction down cold is a classic exam favorite. Okay, so let's get into the weeds on that last one. What in the world is a shunt, and why do we care so much about it?
And this is the definition you have to know. Just think of it like a highway detour. You've got this deoxygenated blood coming from the right side of the heart, and it completely bypasses the gas station, the working parts of the lung, and goes straight back into the main circulation. It's basically pouring unoxygenated blood right back into the clean, oxygenated supply.
But what's interesting is that not all shunts are actually a problem. We all have a small, what we call a physiological shunt. About 2 to 5% of our blood flow does this normally. It's just part of our plumbing. The ones we worry about are the pathological shunts, the ones caused by some kind of disease process that cause real clinical trouble.
And when things do go wrong, these pathological shunts can pop up in a few different places. You can have one inside the heart, an intracardiac one, like a hole between the ventricles. You can have shunts in the large vessels, but by far the most common one you're going to see is the intrapulmonary shunt. This is where blood flows past alveoli that are just not working. They're filled with pus from pneumonia or fluid, or they're collapsed during one lung surgery. The blood goes right past, but zero gas exchange can happen there.
All right, now this is probably the most important part of this whole talk. This is the exam question, the clinical question. How can you tell the difference between a shunt and a VQ mismatch when your patient's sats are dropping? And the key to figuring it out comes down to a really simple, practical question. Your immediate instinct when the sats drop is to turn up the oxygen, right? Well, how the patient responds to that simple action tells you pretty much everything you need to know.
And boom, here's the answer. This is the whole ball game. With a VQ mismatch, the alveoli are just poorly ventilated. They're not getting enough air, but they're still in the game. So if you crank up the oxygen, you flood those alveoli with more O2, and it helps the sats come up. But with a true shunt, that blood never even sees the ventilated alveoli. It's on a completely different road. So giving more oxygen to the working parts of the lung does absolutely nothing for that shunted blood. It responds very, very poorly.
I mean, the textbook itself says it best, right? It's just part of the definition. If the blood and the gas never meet, it doesn't matter how much gas you throw at the problem. That is the core physiological principle you need to be able to explain.
Okay, let's bring it all home. Let's get this down to your exam checklist. If you're going to take anything away from this, these are the absolute must-know points.
Honestly, if you're going to remember one thing, make it this. First, hypoxia is a failure of metabolism in the tissue. It's not just about low O2. Second, you've got your 4 types: hypoxemic, anemic, stagnant, and cytotoxic. Third, a shunt is a complete bypass, no gas exchange. And fourth, the huge clinical pearl: a shunt does not get better with 100% oxygen, but a VQ mismatch does. If you can walk through those 4 points, you have absolutely nailed this topic.
So, everything we've talked about today comes from the textbook Respiratory Physiology. If you really want to do a deep dive for your exams, we definitely recommend checking it out. Thanks so much for tuning in, and good luck with your studying.